Good morning. My name is Deborah Odo-Kant, and I'm a member of the National Academy of Medicine Organizing Committee on Assessing Community Engagement. I'm also founder and executive director of the Health Education Council, a private, nonprofit, community-based organization, which for over 30 years has been devoted to reducing health inequities amongst diverse, historically excluded communities in our region. I come to you from Northern California in the native land of the Miwok tribes. I'm so excited about the release of the Achieving Health Equity and Systems Transformation through Community Engagement framework, which you'll hear more about during our time together. The very title of this framework recognizes that authentic, robust, asset-based community engagement that builds on existing resilience in residents is essential, foundational element to sustainable systems change and transformation. We've long known that core principles of community engagement, like trust, setting a power-neutral table, leading with equity, consistency, shared decision-making, and others, are at the center of how to engage. The foundation of our work at the Health Education Council has and continues to be community engagement and multi-sector collaboration, key to creating healthy communities. As a community practitioner, I've long known and experienced that resident-driven solutions lead to relevant, sustainable change and changes in systems of health. In our work, often we base our programs on documented needs and data only to pivot our priorities, programs, and approaches when we truly listen to residents. This has happened with obesity, pivoting to community safety initiatives, hypertension, prevention and control efforts, pivoting to neighborhood connection and social cohesion programs, just a few examples of how we change when we truly listen. As we emerge from the pandemic, we are mindful that we have experienced simultaneous health, economic, education, food security, environmental, mental health, racial and social connections crises. The pandemic, which clearly exposed inequities so shallow under the surface, has brought a sense of urgency and accelerated commitment to community engagement done in a different, more thoughtful and accountable way. Community solution making to improve systems of health cannot be approached in a status quo manner. In the past, community engagement impact was often viewed as a soft and squishy process, and its impact not fully recognized. Given the complexity of what contributes to health and well-being, measuring and defining community engagement, grounded in community definitions and the scientific literature, has been a step that is most needed. The National Academy of Medicine process of measuring and assessing impact serves to legitimize community engagement as defined in the literature and community wisdom, elevating, documenting, and reinforcing that community engagement is essential to health systems change to improve health outcomes for individuals, families, and communities. I look forward to learning from all of you who lean into asset-based community building and the resilience that exists in communities to transform our systems of health. And now I'd like to turn the program over to Ann Wang and Mona Shaw, who will officially welcome you to our program today and offer you an overview of our agenda. Thank you.
Thank you so much, Deborah. I really could not have said it better, and I'm thrilled to just be able to reflect with everyone here on just the power of listening, the power of community-based solutions, and also the joy, I think, that comes with the unexpected and what you refer to as pivoting. And I think as you hear a little bit about the work of this organizing committee, I think we have pivoted, and this work together has led us to unexpected and wonderful places. And it's an honor to be able to share some of that with this audience. So as Deborah said, I'm Ann Huang. I'm honored to be one of the co-chairs of this organizing committee. I started this work when I was the director of the Center for Consumer Engagement at Community Catalyst. And while I've since left that work of building power among communities to drive solutions in healthcare programs and policies has fundamentally changed how I view my work and my role and the world. And it gives me hope for rebuilding and for recovering from all of the things that have been laid bare over the past 2 years. And I look forward to being able to share some of the work of this organizing committee and the ways in which I think it can lead us forward. So if I think there may be some slides. The first thing I wanted to invite people to do is to take a minute and view this website, which actually, while this shows North America, it actually does have locations across the globe. If you would like to share with us where you are joining us, which native land you are joining us from today. I am joining you all from Boston, which is the native land of the Pawtucket. This is a way to help orient us and remind us of the space that we inhabit, literally and figuratively, as we approach our work and live our lives. So if you have time to join us, to share with us where you are joining us from today, we would welcome that. The Assessing Meaningful Community Engagement project has been a partnership between the National Academy of Medicine Leadership Consortium and the Robert Wood Johnson Foundation. It set out to identify measures that, as Deborah said, can look at a space that has long been thought of as squishy and try to create some structure with the goal of better characterizing, tracking, motivating, and guiding progress. And we hope that the tools that are being developed can help make community engagement really the norm, and to help those who are committed to community engagement make that engagement more meaningful and powerful. So what we're sharing today will be the conceptual model that describes the outcomes associated with engagement. There will be additional materials that will be released over the course of the year, including some impact stories about the power of community engagement, specific metrics that are aligned with the conceptual model, and later in the year, a special publication with additional background and materials. So today, our agenda includes a review of the Assessing Community Engagement conceptual model, a conversation on the use of the model featuring members of the organizing committee, and then we have a panel that will allow for some dedicated question and answer time with a panel of organizing committee respondents. So with that, I'm going to turn it over to Mona Shah from the Robert Wood Johnson Foundation to add her welcome and also give some more logistical information about today's meeting.
Great, thank you so much. Hello, everyone. It's so great to be here. As Ann said, I'm Mona Shah, Senior Program Officer at the Robert Wood Johnson Foundation. I'm in New Jersey, which is part of the ancient homeland and traditional territory of the Lenape people. So thank you first, Ann, for your leadership in co-chairing this important work. And thank you to the National Academy of Medicine for their leadership in developing the work and creating the space for today's conversation. At the Robert Wood Johnson Foundation, we're working to help ensure everyone has the best opportunity for health. And that requires us to listen and partner with people who are most impacted by inequities, so the solutions that we support actually work for their families and communities. For us at the Robert Wood Johnson Foundation, this project is so critical to help understand if communities that we work with feel meaningfully engaged, and to hold funders like us and other decision makers accountable to the communities we serve. As the National Academy of Medicine and the credible organizing committee developed this work, there was recognition that the model should be used to a broad audience. We all know that communities need to be more engaged and have more power and decision-making authority to identify what promotes their own well-being. That is why it's so important to note that this conceptual model is available and useful to a variety of systems who promote health and healthy communities. So regardless of whether you are in hospitals or clinics, working on housing or climate change, or conducting research or making policy, this model can be used to transform a range of systems that promote health, well-being, and thriving communities. So we want to make sure this session is as interactive as possible. So if you have a question at any point during the meeting, the Q&A button that is located in the controls at the bottom of your screen on the Zoom platform. We have set aside time at the end of the meeting for audience Q&A to address these questions live. And we'll use these questions to create a frequently asked question guide that will be available on the project website. And also, since we only have a short amount of time together and doing this virtually, we ask those participating in the meeting to please also feel free to use the chat function on the control panel to share your thoughts and insights. We want to hear from you about what you think about the conceptual model, what you like about the model, and how it could be better. A recording and copies of these presentations will be available to view after the event on the National Academy of Medicine website. So thank you again for being here. And let me turn it now to Aidola Nis, who led this project and part of the National Academy of Medicine Leadership Consortium, to start the next session.
Thank you, Mona and Anne. Good morning, everyone. My name is Ayodele Anishe, and I'm the Deputy Director for the NAM Leadership Consortium, and I'm zooming in from the Piscataway Native Land. It is such a privilege for the Leadership Consortium to be working with the Robert Wood Johnson Foundation, and an absolutely amazing, to use a technical phrase, organizing committee to develop the Assessing Community Engagement conceptual model. We know that many of you have seen the commentary on the Assessing Community Engagement conceptual model, which was released in February. And during this part of the conversation, we're just going to quickly walk you through the foundational standards that were used to develop the model and some key elements of the model. If you'd like additional information and deeper insights into the development of the model and the elements, please feel free to go to the commentary. Next slide. To guide the design and the refinement of this new conceptual model for assessing meaningful community engagement, the organizing committee focused on 8 foundational standards. And these are the standards that you see reflected on this slide. In the interest of time, I'm not going to go through all of them, but we'll just highlight a few for you. One foundational standard for the conceptual model was really defining what should be measured in meaningful community engagement, rather than focusing on what is currently being measured. And so we didn't want to be limited by what already exists in the literature, but wanted to be boundless by leveraging the wealth, knowledge, and expertise of the organizing committee to understand what real, true, meaningful community engagement looks like. Another foundational standard for us was really making sure that the community would be able to see itself in the conceptual model and to identify with the language and the definitions and the context that's being used in the conceptual model. For starters, we used a very broad definition of community, which was based on the CDC principles of community engagement work. And the organizing committee ultimately believes that the fundamental question is not whether entities or end users think they're engaging communities, but whether communities feel engaged. And that makes it even more critical for different communities to be able to see themselves in the conceptual model. At the same time, we wanted the model to be flexible and adaptable to meet the needs of a range of communities and other end users who might be using it. So if you are with federal, state, or local agencies, if you're with tribal communities, if you are in advocacy and work with community and are a community-based group, a funder, academic researcher, a payer, a health plan, or industry, we believe that this model is for you. Another foundational standard for us was really thinking about how we define health and wanting to define it holistically. The conceptual model should emphasize that individuals and communities have the right to thrive. We do realize that the conceptual model uses terms like health and healthcare, but we want to be clear that this model can be used by anyone whose ultimate work is to impact health. And so if you're in education, you can use this model. If you're in housing and transportation or food security, you can also use this model. And then the last foundational standard that I'll touch on is this need to embed equity throughout model. And I emphasize that this was a need. Equity cannot just be the goal or the ultimate outcome that we hope to arrive at for our work. It also has to be embedded throughout the decisions, the core components, and the processes involved in the model. And so for us in the organizing committee, it was really important to make sure that we were finding ways to emphasize the engagement of those who are hard to reach, but also those who are hardly reached in order to open the pathway to true transformation for systems of health. Next slide, please. So once we identified the foundational standards, we started spending time on designing and refining the conceptual model. On this slide, you'll see several of the prototypes that we actually went through in order to arrive at the final, near final version that we're going to be sharing with you today. The very first version of the conceptual model is the one that you see on the top left-hand corner. And this was the one that was developed by a subset of the organizing committee. With all of the boxes and arrows, you can tell that we are not designers. And so luckily we were able to have some design support from Kim Irwin and Tomoko Ichikawa at the IIT Institute of Design, who worked with the organizing committee and specific community leaders to develop over 10 prototypes and using a 3-stage process. And so with their help, we were able to ultimately arrive at the model that I get the privilege of being able to walk you through today. Next slide, please. So we start with the central focus of the conceptual model, which is community engagement. Community engagement for us represents both the start and the hub of movement towards outcome. Next slide. Then we have the core principles, which identify the attributes that should be present in the process of community engagement. Community engagement is and should be grounded in trust. It should be designed for bidirectional influence and information flow between communities and partners. It should be inclusive, culturally centered, equitably financed, built on knowledge of communities and partners, and built with shared governance. It should also be ongoing, co-created, and co-equal. The process of engagement that uses these principles is critical and allows us to move to outcomes. Next slide, please. The outcomes that help to determine if meaningful community engagement is present are divided into 4 domains. Sometimes I've heard people refer to them as petals or propellers, and so you can choose whatever terminology works best for you. And then under each of these domains are the indicators. We know many of you are interested not just in understanding the indicators that you see here, but also the specific metrics that align with them. And those will be released shortly in the next few months. And so starting with the first petal or propeller under strengthened partnerships and alliances, the indicators there highlight the benefits of strong relationships. And those indicators include diversity and inclusivity, partnerships and opportunities, trust, shared power, and structural supports for community engagement. Under the next petal, you see expanded knowledge. And here we see the creation of new insights and resources and stories and evidence. Indicators here include new curricula, strategies, and tools, bidirectional learning, and community-ready information. On the third petal, you see improved health and healthcare programs and policies. We identified indicators that allow for developing solutions that are fit to purpose, in that they are embraced and championed by those that they are designed to serve. And the indicators here are community-aligned solutions, actionable, implemented, and recognized solutions, and sustainable solutions. And then on the fourth petal, you see thriving communities. Here we identified indicators for physical and mental health, community capacity and connectivity, community power and resiliency, and life quality and well-being. Next slide. When community engagement is present, when the core principles are embedded into the process of community engagement, and there is movement both within and across these domains and indicators, we ultimately facilitate action towards health equity through transformed systems for health. As I mentioned earlier, the systems for health are inclusive of all systems that impact and influence health. We also know that there are several contextual factors that you see around the model that influence our work on community engagement. There are the drivers of health and the social determinants of health. There are the drivers of change in health, which are the key levers that influence stakeholder action and include things from grassroots organizing to regulations to financial incentives. And then there are the relevant social, political, racial, economic, historical, and environmental contexts that also underpins all community engagement efforts. Community engagement exists within all of these structural systems. And the organizing committee ultimately believes that true meaningful community engagement can shift not only outcomes in the model, not only health equity and systems for health, but true meaningful engagement also has the opportunity to shift these contextual factors as well. Next slide, please. And so the assessing community engagement conceptual model reflects what we know community engagement to be: dynamic and transformative. When communities are actively and meaningfully engaged, we can catalyze and accelerate the paradigm shift towards equity and transformed systems for health. Next slide. This conceptual model is only one of many resources that we plan to make available. It is the precursor to our, to other resources. By June of this year, we plan to release impact stories, which demonstrate how partnerships and collaboratives have actually engaged communities and assessed their impacts. We will also release assessment instrument summaries, which are based on a literature review that we've been conducting and present specific metrics that are aligned with the indicators of the conceptual model. By the fall of this year, we will publish a National Academy of Medicine special publication that details our methodology for the literature review, the impact stories, and the conceptual model, and also details a framework for implementing and advancing how we measure community engagement. And now, excuse me, I'd like to turn the virtual microphone over to Cincy Hernandez-Cancio.
Good morning, everybody. It's such a pleasure to be here with you today. My name is Cincy Hernandez-Cancio, and my pronouns are she, her, and ella, and very excited to be moderating this conversation about how we can use this incredible work by the organizing committee at the community level. I want to take just one quick moment and especially welcome some folks that I'm seeing that are coming from even outside of the United States to hear this. So very special welcome for all of you. And I also want to give a very special welcome to a few of my fellow Boricuas from Taino lands, although I am here sitting in Piscataway, Manahoic lands right now. So before we start, let me have an opportunity to introduce our incredible panelists. So first of all, I'd like to, their full bios, and you must read them because they're very, very impressive, are on the NAM website. But we have here some incredible representatives of some of the community work that has been done over time. So first of all, I'd like to introduce Takesha Dwan Everett, who is the Executive Director of Health Equity Solutions in Connecticut. Felika Jones, who's the Chief Executive Officer of Healthy African American Communities. Lloyd Michener, who's a Professor Emeritus at Duke School of Medicine. And Nina Wallerstein, who's a Professor at University of New Mexico. So let's start with just some reflections on, and please, each of you just speak up and join the conversation. Reflecting on the expertise and intention behind the development of this model, how do you think that various partnerships or other end users on the ground interested in improving their community engagement efforts, or interested in becoming, or communities who are trying to become more engaged in these efforts, use this model. Who would like to start?
I graciously nominate Nina.
Well, okay, this is Nina Wallerstein. Keisha, no, go ahead, Keisha first.
No. I really do want to hear what you have to say first, if at all possible. We're too gracious on this.
Oh, I'm really delighted to be here. And I'll just say that it's been such a pleasure to be part of the NAM organizing committee and to have such a dynamic and elegant, actually, model produced thanks to the design folks. And what I think it embraces is the core universality of a lot of ways to think. It's not one way to think, it's a lot of ways to think. You know, you can, if you're interested in thriving community outcomes, you can look at those kind of indicators. If you're interested in partnership outcomes, you can look at those indicators. If you're interested in healthcare system outcomes or community-centered outcomes. So I think it's a focused model on principles and outcomes, which I think is really key. You know, the value base we start from, and then the outcomes we care about. I want to kind of defer to talking about what a complementary model is till hearing from others first. But I really do think this is quite an embracing full model. Keisha. Oh,
Yeah, I echo those same sentiments. I echo those same sentiments. I feel as though what's interesting from my perspective about this model, and what I hope end users will engage with and understand about this model, is it's quite comprehensive and quite, I want to say specific is how I look at it. For me, it feels groundbreaking in the sense that it provides a framework and an opportunity to not only assess oneself and how it's doing in relationship to community engagement, but also to provides the markers of where you can go to improve and enhance your community engagement. So to me, it's the both and. Tell me how I'm doing currently, but also gives me the tools to look at how I can improve, increase, and grow, and better and move to better community engagement and improvement of that. And doing so in a way that really leads us to what I personally subscribe to is meaningful communication, meaningful community engagement that's transformative, that centers equity, and that changes systems overall. So to me, that's what I hope end users are able to take away, utilize, and actually gain from this. And as already mentioned, I think it's ever evolving and ever changing. So I see it as a well thought through start, but not a complete finish line, if that makes any sense.
Lloyd, do you want to add anything at this stage?
Sure. I really have also enjoyed the meeting and the discussion. I should add that I'm from Durham, North Carolina, the land of the Eno. But I think what's been really helpful about the model, and the way in which I hope it's useful for the academicians and researchers in the group, who often go directly to how do we improve health or how do we expand knowledge, that really the center of this, if you look at the model, is about engaging with communities. But beyond that, there are principles about how you do that, around trust, bidirectional, that it's you co-create, there's common governance, shared governance, multi-knowledge. There are core issues, the principles that one needs to embrace and work on as you engage with communities while you pursue these larger additional goals. You can't do it without engagement. And I hope this serves as a powerful reminder, visual reminder about where you start.
So I think given especially what we have gone through the last couple of years with the pandemic, I wonder if any of you would like to comment on how those experiences have either heightened or understanding about the need for community engagement, and in that context, the utility of a model like this for moving forward.
Well, I'll start in saying I think what we've quickly saw from various aspects of what we're living through the pandemic, both from the outcomes we saw from an equity standpoint, the challenges individuals faced on the community level and trying to access uh, needed healthcare, needed social needs and other items, and moving that all the way through vaccine distribution and access and who's getting it and who's not, is that there is a vast amount of distrust and mistrust that exists between communities, health systems, the government, et cetera. What is enthusiastic for me is that whether you call this a propellers or pedals, this model helps to really understand that trust has to be at the core of what you're doing in community engagement, or otherwise you're not doing anything that's more than a transactional opportunity that you can check the box and say you've engaged community. So I see what we've learned from the pandemic is that there's no more urgent time than the ever important now to really begin to understand, one, when we say community, defining that very clearly and explicitly, two, building those trust models. And I think we have a foundation that we've seen in a lot of states and in a lot of health systems who've built trusted messenger opportunities and campaigns to build those bridges and to now really begin to take, if I should be so bold, this conceptual model and determine how do you fully integrate meaningful, transformative community engagement throughout everything that we are intending to do from a health system and health policy perspective.
I think I would add on my personal experiences, having worked with tribal communities for 30 years, watching the leadership emerge and the centering of the actions from within communities has been incredible. Also, partly to deal with the suffering that those communities endured during the pandemic and excess mortality and morbidity, but then the leadership that these communities took in trying to create programs and practices and actually pivoting to food distribution instead of health research, food distribution instead of other kind of superfluous issues, and therefore the trust that had to be rebuilt from healthcare systems and university systems that were saying, no, we have to do this, but the communities knew what they needed to do to protect and their own tribal members. And I think that that was a key lesson for me in being a part and a partner during this time with the communities that I work with, and recognizing that those principles, as you mentioned, Takesha, trust, but also principles I would actually name specifically shared governance and shared power, rather than the power coming from the university or the healthcare system, where how can it be equitable power so that the real needs and priorities of the community are first and foremost. And that's embedded in the model of that sharedness and bidirectionality. And I would also say multiple knowledges. The communities had the knowledge of what needed to come first and during this pandemic. And also, of course, they needed the resources that, within healthcare systems, the vaccines, the distribution, the testing, all of that was key, but that wasn't the only need. And so I think the healing that will come now and the resiliency that they're building from now is even more important, to pay attention to the priorities of their own knowledges that are going to emerge as key for thriving and healing within those communities. And how can we, or me as an outsider, still be an authentic partner and share that accountability to those communities? And I think those principles are pretty embedded within this model. I just called out a few others to think about.
If I could add on to that very briefly, just to build on it, but also to address a weakness, because there's a question that's come up in the chat about that. It's a lovely model, but one of the things we've learned from COVID is the communities differ, and that we tend to think of, or it's easy to think of community as a broad generality, but communities have their histories, their different norms. And you don't have community engagement by picking a couple people you know and putting them on an advisory panel. What we've been talking about here is we call authentic community engagement with those principles that Nina's talked about and we put in the model, like shared governance. But you need to know what the community, who the community is, and what their history and traditions, what their strengths are, so you can build on them together. So I just underscore, we've given you a general model here, but it applies to specific communities, or it's really powerful when applied to specific communities. And that requires that relationship building community, one community at a time.
Thank you so much for those comments. One question, one thing that is very apparent in the model, and it's also coming up in some of our questions, is the issue of trust, which obviously lack of trust is something that has been an issue within healthcare and other spaces for a long, long time. And the pandemic kind of elevated that there are two issues with like not trusting. One is like the issue around fake news and fake information, and the politicization of public health, right? Which the system has been really focused on, like, well, those people just need to figure out like that they're being lied to, and listen to the experts. But there's a very different reality when it comes to the trust issues in communities of color and other structurally marginalized communities, where not trusting is actually rational, not an irrational response. And so given that reality and our recognition that trust needs to be the foundation of community engagement, what do you do with the fact that the trust is not there already? Do you have suggestions or examples of what being trusted requires being trustworthy, right? And so how can we change the way we're doing our work using this model to center and figure out how do we start being more trustworthy? And I think that's really relevant to one of the questions that came up about the fact that there are communities who simply do not feel safe. And the lack of safety is something that obviously is going to affect their ability to engage and to trust that they can stay safe. So any comments about that? I'd like to start with Nina, because you always have such brilliant things to say about this.
So maybe I will return to what I wanted to also share as a complementary model. Some of this model did emerge from other models that have been in the literature and in the empirical work. And one of them is our Engage for Equity community-based participatory research conceptual model. And that actually tries to answer that question, Cincy, of how you build the strategies to make change. I think what's complementary about the CBPR model that still is available to people is it works with pathways. It starts from this idea that Lloyd mentioned, that context matters. The local context is different in tribal communities and African American communities, in Puerto Rican communities, and even in different localities of the, I can't work in one tribe in New Mexico and think that it's exactly the same as working in another tribe in New Mexico. All of those local contexts differ, the histories differ. How do you even begin to understand those histories? Our CBPR model says that the histories then impact the strategies, the partnering processes. And we divide those in empirically. We've actually surveyed over 400 partnerships around the country. We know that there are structural ways to build trust, and we know that there are relational ways to build trust. You can be a good person, but if you don't have formal agreements that codify shared governance, if you don't have shared participatory decision-making that's codified as this is the way we do it in a structural way, trust can be broken very fast. So we've built pathways from context, understanding the context, knowing then that impacts the partnering processes, both structurally and relationally. And that then impacts all of the actions that you take. The domain of your research or your programs or your practices is based on how you build your structural practices and your relational practices. And then that builds the equity outcomes. So the CBPR conceptual model is 4 domains, not 4 outcome domains, but starting with context, going to partnership processes, then to actions and research and intervention or practice actions, which then lead to a whole variety of specific outcomes related to education, economics, health, housing, or also related to equity and also related to social justice. So these are 2 complementary models, and this important idea that just because you say you are going to do trustworthy things does not mean you're doing trustworthy things. So I urge you to look at pathways, and I think any model needs to start looking at what are the pathways and strategies for good engagement to get from values to outcomes. And I think that's what's complementary about the CBPR model is we have empirical data about what are key good pathways to make change. So I think that that's kind of 2 models that can be thought of together as helping move us in this direction. And I think with the new model, the new NAM model, we do have to look at pathways. We haven't done that yet with the new model. And so I think that important way of just focusing on trust for a minute, there are structural, formal ways to kind of move together so that you can build trust. And over time, trust is not you get it and then you're done. Trust is a daily action. And so you have to prove that daily action, both structurally and also how you relate to people relationally. And so I think that I'm hoping I didn't overwhelm this answer here, but I do think there's 2 things I was trying to say. One is that the pathways in any model are something to really be thinking about. Strategies are important, not any community engagement. Any action, it doesn't build trust, but really what are the best and promising practices that build trust or build shared governance or build the way to those outcomes that we all care about. So thank you.
Takesha, I'd like to ask you, because I know that you have been at state level doing a lot of organizing with communities on health equity issues. What does it take to function and act in a trustworthy way?
Yes, so I'm going to start with a kind of plain sentence and then I'll explain it. I don't know if it's plain, but it's the sentence that I have. Acknowledgement without internalization and action to change means nothing. So let me explain what I mean by that. To be trustworthy and to gain trust, you first have to acknowledge that trust was broken and or was never there. But a mere acknowledgement of it without internalizing what that means and actually building into it the reality of what change looks like is worthless. So when we're talking about building trust, oftentimes there is a challenge that no one has acknowledged that trust isn't there. It's we have to build trust, and no one wants to acknowledge that you weren't trustworthy at the point of engagement. So when we start asking questions like, I don't understand why the community just didn't show up when we asked them to come. I don't understand why we can't get the outcomes that we're looking for when we've engaged the community. We've asked them what they wanted. We've done what they wanted. The trust, the line and the bridge to trust was not there. It was broken already. It didn't exist. And you have acknowledged that. Once you've moved to acknowledging it, you have to internalize what that means. And you have to assess and understand what is going on? What do we need to do differently? And it's not a question you can ask on your own. We can't ask ourselves, what do we need to do to change to be trustworthy if we're not getting the input to understand why the trust was broken? So to me, it goes back to this model, the bidirectional learning, the bidirectional conversations, the understanding of the historical and contemporary reasons why people do not trust is really important. And it comes to that action, as Nina was saying, building different structures, building anew, putting in the direct pathways, the consistent assessment of that trust, the consistent acknowledging when you have misstepped. For me and in my work, that's what has made the difference. It's not coming in saying, I know better, I am better, we are better, be better. Those aren't the statements. It's the 100% acknowledgement. There's a broken there's something broken here. Tell me what it is. Let's discuss how we fix it, and then let me hold accountability for myself internally, as well as you hold accountability external for me building that trust consistently. And let's continue to evaluate and understand this over and over and over again. That's the only way we're going to be able to build trust and to maintain that trust and to maintain authenticity.
And thank you, Takesha, for that. And I think there's even a finer point in that a lot of the way that the academics and policymakers and decision makers have approached these issues are like that something got broken. And let's be real, it's not broken. It was designed that way, right? And not acknowledging that, there was never trust, that, the government and corporate actors never were not even thinking about trust, and acted in extremely untrustworthy ways because they designed systems that were intentionally made to not work for these communities, right? And for our communities. So that's, I think, another aspect of like, you're not rebuilding something, right? You're trying to change something that was never intended to work for you and for your community. And if we pretend that it was, then we're not going to get anywhere. So I wanted to follow up and see, Lloyd, if there was something that you wanted to add.
Yeah, there is. And it's been a wonderful discussion, but I want to draw a sharp line or underscore a point about there's being trustworthy as a person, as an individual, and there's being organizational trustworthiness. And we often tend to think that I'm trustworthy and therefore there shouldn't be a problem, forgetting that we're part of organizations that, as Cincy well said, have other agendas and have histories that may make building trust or earning that trust quite complicated and challenging. The other point, and I'd add just briefly, is I made the comment that community, you have to build trust. It's a relationship issue, and it's one community at a time, but communities have commonalities, and you actually can work collaboratively. And many folks on the call have histories of doing that. My point is just to not assume the communities are alike until they discover that, or until they decide they are, or find the similarities, allow them to find common solutions. But again, to Cincy's point, what the model helps us do is build those bridges and commonality so the communities, plural, are at the center of the work, and we're supporting that work and building on their strengths. But it's us as individuals and as part of our own organizations doing that.
Thank you, Lloyd. And we're getting a lot of questions, related questions also around power, right? That at the end of the day, what we're seeing, this is all the result of, I want to point out my a wonderful thinker out of right now Morehouse, Daniel Dawes, who wrote about the political determinants of health. Because I think one of the things to really think about is that sometimes we're thinking about these contextual issues as if they were like, I don't know, the weather, and not the result of decision makers making decisions and choices where some groups and some communities are consistently not allocated the power, the health assets that in equitable ways, and are also then piled on a lot of risks to their health. And that is not a coincidence. That is not something that happens like the weather. It's something that is a result of actual decisions, right? And so that boils down to power. And we're getting some questions around, what is the difference between, engaging with the community versus actually sharing power? What does that look like? I like to think about this as like kind of the vanilla ice principle. Bear with me. You got to stop, listen, and collaborate, right? And instead of stop, collaborate, and listen. But I think the question here is what does collaboration really look like, and how can it be more than just really relying on the goodwill of some great people? What happens when those people are gone? Or what happens when that person, bumps against their limits of power and ability to make decisions in the system? So Any thoughts? I'm sure there are a lot of thoughts about that. Who would like to start?
Well, I think I'll try. Maria Aurora just wrote this beautiful piece from looking at micro, meso, and macro levels of power. And I think, partnerships are kind of in the micro and meso world, but the history of macro power issues of genocide and attempts to assimilate and forcing people off their land, and those are macro issues, at nation and global states. And of course, different nations have different authoritarian domains of power or democratic domains of power. So we're in multiple contexts again. And so how do we as partners or individuals, as Lloyd was talking about, try and break into those institutional and structural histories of power? I think is a really huge, huge question. I think it's probably bigger than what's even in the model. And I think we need to acknowledge that the model doesn't quite go there at that macro level in those histories of, that have to be challenged. But I do think it's the central part of engagement. Power and equity are in the model, which is beautiful, but really understanding where they come from, those histories, is not. And so I think we need to kind of think about always bringing that to the fore, and what can we do? I'm in the middle right now of looking at institutional barriers and what are those institutions at different institutions, Morehouse being one of them, and just interviewed Daniel Dawes, and he's a wonderful, wonderful thinker and wonderful proponent of the political dimensions of health and of power. And I think that that kind of looking at the different institutional changes that we need to promote, not just out in communities, but in our own institutions. I guess I would add that bidirectionality to make us be aware, that's in the model, the bidirectionality, that we need to transform not just communities, but we need to transform our own institutions that we work in that are part of the system that make it difficult to do authentic engagement. And I think it's really important for us to be looking at policies, practices, norms, climate, all, the dominance of, white academics versus academics of color. I mean, I think there's a whole change that has to, historically, we have to still demand those changes. So I would just thank you for that question.
Lloyd?
Yeah, if I could, as usual, build on Nina's comments, I'd underscore that things are changing. We have a long way to go, but there's a lot more interest in this topic than there was 2 years ago. I mean, for those of us who've been in this field for a long time, there's a sea change. And I think this is a time for folks to take the model and to help our institutions along on the journey. So we have everything from academic health centers are saying, okay, what do I need to do and how do I do it? Which is a change, because they used to be, they didn't care as much. And you have the AAMC with its Center for Health Justice, with coming out with guidelines and recommendations. You got the states in the California Reducing Disparities program, and you have groups within the organizations. This is a time to network, connect, and not assume that the groups who didn't know how to do this or did it really poorly before are still incapable. That may be true, but it's a good time to connect and start being part of larger coalitions, really to help our communities be healthy and to change our institutions so that they support that.
Thank you. And we're running out of time, but I want to give Takesha an opportunity to answer the question.
So I first want to acknowledge my headphones died just as this powerful question came up. So forgive any background noise, and I'll try to be brief in saying, for far too long, and the United States generally and in our world, we've confused power and authority and have mistakenly thought that because people had the legal structural framework of authority, that dictated who did and did not have power. And far too often, individuals, both in community and communities of color, as well as in authority, have really thought that power rested in your legal framework of who had authority, in the social framework of who we thought was powerful, rather than understanding that people have always been powerful. Even when subordinated and oppressed, there was always power that rested in the hands of the people. And that's why there were structural decisions to discriminate and to try to strip people of that power. So in answer to your question, for me, connecting this to this conceptual model, dissecting that difference between power and authority is really critical. And remembering that change and what we need to do for communities is always rested in the power of the people who lived in the community, not the people we have elected and given authority to.
Thank you so much, Takesha. What a way to end this section, this section. I hope folks were taking note. And at this point, I want to thank the panelists again. Always wonderful conversations when you guys are involved. And I want to now hand this over to the moderator of the next session, which is our organizing committee members addressing audience reactions and questions. And for that, I'd like to introduce Bobby Milstein of Rethink Health. And again, thank you all so much for this opportunity, and to the panelists for being part of this conversation.
Yeah, thank you, Cincy, and to all the participants. In many ways, today's session feels like an expanded version of conversations that we in the committee have had for a while. I'll just say I'm imagining the word cloud that we're talking about here that is infused with this understanding of human plurality. We are not one people, we are not one community. We do not all have common interests necessarily, but we do inhabit a common world. And this framework in many ways talks about what is it going to take for us to be able to create communities that are built for everyone to thrive together, where it's an expectation that well-being and equity and racial justice and the things that are laid out in this framework in some ways are built by design. That is hard work, and our histories have never really lived up to that potential, but our future can. And I think that's really where some of the distinctions in the conversation I've already heard today. This isn't necessarily only about doing something or one thing. It's about doing lots of things with integrity and coherence, like doing it for real with devotion, like our lives and all of our lives, our future depend on it. That's where some of these distinctions matter. I loved what we just heard about the distinction between authority. Authority is not the same thing as having power to do things that none of us could really ever do alone, or the meaningful distinction between trust, believing you have it or assuming it's there, versus earning trustworthiness over and over again. And that may matter at an individual level, like I as a person, I have integrity, but my organization has a history that I didn't have a hand in necessarily. It has a future that rests on how we build it together. And so the Lloyd's point about individual practice in this versus organizational history and context matters immensely. We've talked about, Nina, I heard things about, having principles is one thing. Having pathways to be able to bring those principles to life is an entirely different enterprise. And of course, we've got longstanding champions who forever have been doing this work. And we need to acknowledge the traditions and ancestry that we're stepping into here. And there's also newcomers. We need people who haven't been thinking about this. Lloyd mentioned the moment that we're in is increasing attention to this. Lots of folks in the chat acknowledging that they are sitting in the midst of opportunities right now where this feels relevant and useful, and how can we make the most of this moment. So I am delighted to have 4 other colleagues from the committee here. We've got Merritt Felzine from the High Plains Research Network, Marita Jones, Executive Director of the Healthy Native Communities Partnership, Bert Pusch, who's a member and consultant at the Commonwealth Care Alliance, and Richard Zalvadar, who's founder and Executive Director of the WAL Las Memorias Project. So I really want to begin our dialogue today, and it's going to be too short, but each of you helped to guide the development of this conceptual framework. And one of the things that's unique about the process that we've gone through here is that we didn't just turn to what you would find in a library or a bibliography to try to repeat and summarize what what we think. We brought our own life experiences to this. And so I'm wondering if you could share a story about things that you've done in your own work, in your own life, that come through as important concepts in this framework. What is it in your own life that actually has shows up in the concepts that we're putting forward in this framework? So we can start in any order, but I'm seeing Richard first on my screen. So Richard, what about you?
So let me see if good morning to you, wherever you are. Let me see if I can answer the question. You know, I just want to go back to real quickly the whole issue of trust, trustworthiness, and power, because I like to say that a lot of our communities throughout this country have power, but they don't know it. A lot of our people that are out there in the front lines are talking about COVID-19. I saw a lot of innovation among community workers, right? Who are out there finding ways to recruit people for vaccinations and COVID testing. They have power. And I think the one thing that we need to do is find a way to trust ourselves, trust our own voices and our leadership capabilities. But going on to our own personal experience in the organization, I think one of the programs that we created was an Act Now Against Meth Coalition, where we organized from the bottom up, brought people together, over 20 organizations to address the meth epidemic in Los Angeles. And from that, we created a platform where we came up with 32 recommendations on prevention, treatment, and policy. Now we're working with the County Board of Supervisors to ask for an adoption of that platform, or to finding ways to better serve our different communities out there in addressing crystal meth. And I think one is organizing, two is building collaboration, three is articulating our concerns and recommendations, and fourth is moving into action. I hope I answered it.
Yeah, that's lovely. Who else? How about Marita?
All right. Thank you. Yat Marita Jones and Chiet Twitch in Schlant. There's a plan of Bashichin, but Ahni Dasha Chedo Kia Ani Dashanala with Astanchle. So I am Dene Navajo from Shiprock, New Mexico, and really happy to join this panel. And something that, a story, I guess, that resonates with me with this project is around the medicine wheel. So a lot of the work that we do is grounded in the medicine wheel, always starting in the east direction and going to the south and the west and the north. And I represent, I think, the work that I do with Native communities all around the country. So even though we're based in Shiprock, New Mexico on the Navajo Nation, I get the honor of working with tribes all around the country. And I have learned so much. And I think, you know, that power conversation really sticks in my mind as well. Is, you know, we had a leadership program that started in 2005. And to me, your comment, Richard, about people don't know they have power, it really resonated, because the first time we took a group of 50 Natives to Washington, D.C. to learn more about the political processes. Stacy Bolin at the time from NIHB, National Indian Health Board, asked how many of you voted, and it was during a voting year and for the president. And probably out of those 50 people, probably 5 people raised their hand. And the questions they had was, or their conversation was, I didn't know that I could vote. And I didn't know that I could vote, you know, in national elections, in regional processes, and at the state level and county level. And that just brought that to mind when you asked that question, Bobby. And also that throughout my work for 20 plus years. It's, well, I think really trying to remind people that we have wisdom in our own communities. There are strengths that have sustained us through time immemorial, and that we need to acknowledge that. And I believe that we did have to cover up some of that traditional and cultural knowledge in order to survive to this time, and that now is the time to uncover that strength and those cultural values and traditions and bring them forth, because that is what has sustained us throughout this time. Yeah, thank you.
That's lovely. And I'm already seeing a strong connection with what Richard said about these hidden assets, but that may be hidden to ourselves, but also hidden from others because the circumstances haven't really been welcoming for that. Merritt, what about you?
Thanks, Bobby, and hello, everyone. So I'm Merritt. I'm in Sterling, Colorado, the land of the Oglala Sioux, Cheyenne, and Arapaho. And this was such a pleasure to be part of this process. And to address Bobby's question around, kind of how did our own experiences get woven in and guide the process? I first want to just state that the process had to create trust among us, and also had to figure out how to share and give and value power. And so, as you all know, and many of people have been chatting and the chat has been so rich, that's not an easy process. And so obviously this wasn't a quick nor seamless nor streamlined process. And I want to say that in many ways it was messy and it was complex and it was wonderful. Our own voices came through in that not only were we engaged in just sort of discussions, and oftentimes the discussions really ran much like they've done this morning, and we would chase down an idea for as long as needed until people felt like their points had been heard and we could kind of collate that back and bring it back to the group. But we were also allowed to share personal stories and one-on-one opportunities to really embody the work that we had been involved in for, in some cases, decades, and to show how our own work, our own experiences, our own wisdom might be informative for the process of this conceptual model. And then finally, there were lots of different ways of learning. And so we used voice and conversation and rich discussions like this, but we also used opportunities to sort of take information, reflect on it, and write back what we thought was missing or what wasn't elevated enough or what was repetitive. And so I'm just, as I reflect back on this long process, complex, messy, long process, just the levels in which we were able to insert our experiences, our knowledge were really to be commended, and allowed for within this own process a lot of trust, and to give kudos to those who were guiding this, the funders and NAM staff. They realized when they needed to really back off and back up and take more time, but they also were able to take complex information and sort of reorganize, let us readdress and rethink. And so it just was a really interesting process.
That's lovely. So many themes to return to. Bert, let's bring your voice in. What's your story?
I, as a person with the lived experience of disability, I have dealt with this almost all of my life, both personally and professionally. I've been thinking about this conversation, which is wonderfully rich and wonderfully deep. And I think one of the things that brought me into it was I did not accept the traditional story, if you will, or construct of disability early on. And because I didn't accept it, I didn't, if you will, fall in line and start believing things as if they were true about who I was, what I was capable of doing. And I've tried to bring that into all of my work. I think one of the first and most important things is to help people who are disenfranchised deconstruct those models that they've been told are true about them. And often they're not. People with disabilities are capable of doing a whole variety of things. We've seen that in the recent, the recent Oscars. But we don't really encourage folks to take a look at what truths, if you will, are guiding their self-impression of who they are and what they can do. And I think by doing that, by helping them deconstruct what they're being told they're capable of, or what they're being told they can and can't do, I think we help them reconstruct value for themselves. I was a professor in the field of rehabilitation, and I left it because what I found was that we had a lot of able-bodied white people, males mostly, who were interpreting studies by other able-bodied white people who were about people with disabilities. And when I got into the field myself, none of that was true. I mean, and maybe that's because I already have a different model. But I think one of the things we haven't talked about is helping people who are disenfranchised to look at and to ask questions about, not merely accept, the kind of constructs that have been built around who they are and what they are capable of doing and what their worth is. And I think by doing that, we give people a sense of agency. You can't empower people. You have to create opportunities for them to empower themselves. This is, people who have power rarely give it away. I mean, if you really think about this, right? We have all these groups that, well, we want to help this group, we want to help that group, but are they really giving them the power to be able to be self-actualizing and have agency in identifying solutions, identifying problems, identifying the matrix by which success will be determined, and given the supportive resources they need to get there? Is that what we're really doing? Or are we just saying, oh, hey, I'm going to give you some money because I'm going to keep this power differential between us? And I think we have to stop those kind of things and really get people to think about the system they're put in and what they can accept, what they can't accept, and redefine it for themselves.
And one of the things implied by the design is that this is a dynamic, right? This is a constant flow, and I think all of you have spoken to that idea that this is a work in progress. Not only our understanding of what it takes to do this, but the experience of actually interacting with people across difference and being able to discern what have we learned and what have we done through iterative action, or in some cases inaction, and being able to admit when the master narrative doesn't match our experience, and being able to also act into that in ways that tell a new story, a story of human capability and agency. And so maybe let's turn to questions about what you think this work means for the kind of contributions that can happen in differently situated organizations, right? Hospitals are not the same thing as academic centers, are not the same thing as policy or service delivery organizations. But for people situated in different roles, what does this work mean for our ability to be, let's say, vigilant about learning from both lived and learned experience, building power together to do things we can't do alone, actually channeling investments toward the things that really matter? These are hard challenges that we all need to contribute to. So do you have thoughts about how organizational leaders can fulfill these principles in a world where we're constantly imperfect and muddling through in some ways toward a higher purpose? I'm seeing some heads nod. Merritt, I'm going to start with you on this one.
I don't know if I'm brave enough to speak to organizations and how they might use this. But I'm going to frame it this way. So I'm community. I'm not a doctor. I don't work in health research. I worked is community engagement, true community engagement. But I know what good community engagement looks like. And I know what not so good community engagement looks like. I understand all the muddiness and the inexact science in the middle, and that there's magic that happens and that there's also intention that happens. And what I love about what this process has done is it's tried to capture what's magical, relational, vulnerabilities, just sort of this natural sort of human gift to work collaboratively with a group of people, and tried to put it, and I think very successfully put it into a framework that now our organizations can actually respond to. And I'm so excited for everybody to start to see the body of work that's behind this model, because the depth and the richness of it, from which one can sort of dive in and figure out what do each of these components look like? How do you measure them? How do you access them? How do you actually sort of say, do we have it or not? That this is finally something that has pulled together bodies and bodies and bodies of work and immense effort from so many incredibly smart people and tons of history. And I think we finally have something that is very user-centric from both my level, working in the community, geographic community of rural America, to an organizational level that's trying hard to sort of walk the talk and hopefully pay for it at the same time.
Mm-hmm. That's nice. Marita, what's on your mind about this?
I too am really based in grassroots community work. So it just made me think about when I was first invited to join this committee. I was telling my colleagues that, I felt like a fish out of water. It was like, first of all, I'm not a research person. So my brain was just twisting, trying to figure out what everybody was talking about. I was like, I don't have any idea what you guys are talking about. But what drew me in was really the model. I like that Ayadola showed that how the visual of this concept developed. And I think I met first with Kim Irwin, and when she showed me the model, I think that was my first contribution. I was like, that does not resonate with me, and it doesn't make sense to me. And so I think that was really helpful to me in helping to draw me in and to participate. And I've learned a lot. But what brought to mind your question was, I work also with Indian Health Service at the Shiprock Service Unit on Navajo area Indian Health. And they really have some awesome people there that are really trying to engage their medical staff to learn more about the Navajo communities that they serve. And one of the ways that we're partnering together is to figure out how to keep more of the doctors at Shiprock. So most of the doctors come and do their rotation, or, they're doing their payback to the federal government, and they only stay 2 years, at the most, and then they leave. And also in partnership with UNM, we're trying to work together to see if we can develop a medical residency program in the Shiprock area. And so they found through studies that most residents, wherever they do their residency, that they stay there. And so our participation is trying to connect those students with the communities. And it's not really about curriculum, but really to become immersed in those communities and help to figure out how they can help the communities or collaboratively work together on different projects. And so to me, I think of course, the medical doctors know their stuff, and that's what they're good at. But we really want people to stay in Shiprock, to stay on Navajo, because that's one of the core components is trust, right? And relationship and getting to know each other. And it's not just one way. And what I hear a lot is, it's like how can I build trust with the community? Like it's one way, but it's really, interactive, right? They have to build trust with us too. So it's a two-way street. And how can we do that?
Yeah,
And
and I'm
I
hearing
really
so
appreciate this model.
Yeah, and I'm hearing so clearly from you that the rootedness in place also matters, right? How do we do this here in a way that works for us? Um, uh, Time is going to be the enemy here, but Bert, what about you?
I think leadership plays a big role in this. One of the things that I was brought on to do was to develop a program whereby we go to our members, i.e. people who have very complex care needs, and are usually, to be honest with you, the most expensive members that a health insurance or healthcare company addresses. And my job was to bring in the member voice into the way we either initiate new products or redesign products that are currently there. And it has been a fascinating journey. It is very iterative, to be honest with you. I mean, we're learning as we go, but I think the first part was making sure we had the accurate representation of the diversity of people who will be using our products. I think having this has also grown throughout the company, meaning I believe in our first year, we had 5 requests from different departments, and now we're dealing with literally 100 or so in a year. So things can and do change, but I think there has to be a commitment to this. And I think there also has to be what I call authenticity. I think you have to be truly, truly committed to the authentic voice and sustaining that authentic voice in all that you do. It's my biggest fear, because I've seen this happen. My biggest fear is that people will take these concepts and then they'll be reinterpreted to conform to current thought and current practices. So basically, we're giving new words to the same old, same old. So I believe that a true authentic community, we should expect 3 things. One is, if you have an authentic community, you're going to see things differently, if it's truly authentic. Number 2, you're going to respond differently because you're really hearing something you haven't heard or understood before. And finally, I think you're going to change in ways that you may not have ever considered. And I think I've seen that as we've initiated this it's called Member Voices throughout CCA, Commonwealth Care Alliance, that people are starting to realize that as the quote medical experts, maybe we don't have all that information about the lived environment, the social determinants of health, and other things that are really important, like value, sense of ownership, sense of trust, sense of being listened to and respond to. We don't necessarily understand how important some of those variables are. They're not superfluous. They're actually core to a lot of the work that we're trying to do.
Lovely. I love that attitude toward discovery and the unknowing of what's going to come next, but the co-production of that is really the important thing. Richard, you're going to have probably the last word on this panel, but I just maybe just bring up a theme in the chat about where does the resourcing of this figure into this work? Like follow the money in some ways. You've built an organization and founded one that wasn't on the map years ago, and now it is. And so if you could speak to this sort of the near edge of doing this work, but also building the resourcing commitments that are required to do it.
I think for me, I think it's important that one is that we trust our vision, where we're going with our work, if it's a community-based organization or if it's a hospital, and utilize this incredible model in our application for grants, for funding, and then having conversation with policymakers about acknowledging and accepting this model and community engagement. I think that is essential. We are, and the community members out there throughout this country and the world are really the teachers. And if we get this under our belt, we can educate the others in the systems that we constantly work in and are challenged by, and never take no for an answer. Because I think, again, this is a great opportunity to use what we have learned here, what we created from a lot of folks in the country throughout the various communities and barrios, and to utilize it as we move forward. So I'm going back to your original question. How do we educate the folks in the different fields, in different institutions? We got to speak up, move up, and educate as we go along.
Lovely. I'm going to turn now. Thanks to all of you for sharing your wisdom and for the work that you put into creating this for. There will be more to come. This is imperfect and evolving, as you've all said. I'm going to turn now to Sergio Aguilar-Garcia and Monique Shaw, who've been our organizational champions of this from day one. Thank you.
Thank you, Bobby. And I'm Sergio Aguilar-Garcia, a co-chair of this work group. And I'm participating from Sacramento, California, the land of the Nisenan and indigenous people of California from the Yuba River and American River watersheds in Northern California and the California Central Valley. I do thank our organizing committee and all of you who participated in this important meeting and who also shared your valuable comments in the chat. Meaningful community engagement is a dynamic, transactional process that is not linear, but a continuous, multi-directional, transformative learning experience that requires time, involvement, dedication, listening, and flexibility, in which building trust and being trustworthy are front and center. It is also of critical importance to properly identify community needs and work collectively to meet them, as it is also to identify the strengths, assets, and resiliency of communities. Our response to the multiple challenges of the pandemic has taught us that it is crucial to start meaningfully engaging and developing relationships with communities now. And the assessment and evaluation of that engagement is an essential step in this process. It's been a pleasure to have this meeting, which is a public meeting after three years of this fantastic work group. And as mentioned by Anne Huang and Ayudola, the release of our ACE-COM conceptual model is the first of other additional materials that will be released to support the use of the conceptual model. Please stay tuned for upcoming impact stories, metrics that align with our conceptual model, and also for the NAM special population. I'm now turning to you, Monique.
Thank you so much, Sergio, and hello, everyone. I'm joining you today from Jenkintown, Pennsylvania, the land of the Lenni Lenape. I'm Monique Shaw, a program officer at the Robert Wood Johnson Foundation. We've heard a really great discussion and reflection today, emphasizing the value and absolute necessity of authentically engaging those with lived experiences and those most impacted by inequity in the visioning, decision-making, planning, implementation, and revision of efforts designed to advance health and equity. Building upon and sustaining community engagement requires a paradigm shift and bold and innovative approaches that disrupt traditional models of engagement, where community voice is prioritized, the agency of community members is increased, trust is earned, and the partnerships and alliances strengthened. As we heard today, the use of the conceptual model for community engagement, when applied to specific community context and with intentionality around processes and action, can lead us to outcomes that promote equity and justice. We've also heard that distinctions between power and authority must be dissected, particularly as we address structural barriers that have been put in place by design to reproduce inequity and maintain the status quo, oftentimes only benefiting those with deemed authority. This was a wonderful webinar and discussion with so many important insights and stories that have been shared. I'd like to give an additional thanks to the rest of the organizing committee and National Academy of Medicine staff that helped make this work and webinar possible. If you have any other input, want to continue the discussion, or receive notices about the additional materials being developed,
please visit the URL available on the next slide. We also want to leave you with a call to action. The quote that has guided our work is that knowing is not enough. We must apply. Willing is not enough. We must do. As we end this conversation, what will you do next to ensure that not only is community engagement taking place in your work, but that it is being measured to ensure that it is meaningful and impactful? On behalf of the National Academy of Medicine, the Robert Wood Johnson Foundation, and the organizing committee, we thank you so much for joining us, and take good care.